Welcome to the Dogtor Bros, where we have an honest discussion around vet life in and out of the clinic. My name is Chris, and I'm your doc of the day and your guide through this episode. I'm a veterinarian in Winston-Salem, North Carolina, and I'm here with my closest friends.
Hey, this is Adam. I'm a relief veterinarian in Louisville, Kentucky.
Hey, this is Brandon. I'm a small animal internal medicine associate veterinarian in Colorado.
Hey, this is Jeff. I'm a veterinary dermatologist in Louisville, Kentucky.
And this is Chris. So today's episode, we're going to be talking about tier listing or seeing which one is our favorite or best medication for anti-itch control. But before we get into that, we're going to do one of our opening questions. And we're going to play a game of Would You Rather. Made up all these questions. Everyone does not know what these questions are. So the first one is, would you rather, and you have to do one of them, stabilize a GDV or perform a linear foreign body surgery?
This is Brandon. I would easily do the GDV stabilization. I don't want to have to cut anything, and you can trocar that stuff if you have to. We actually had to help with one recently because our ER doctor was out and one kind of came in at random. So I was a little bit involved, but would much rather do that than actually do some sort of foreign body surgery.
Good answer. And what if you had to go in surgically?
If I had to go in surgically?
So basically you're asking which surgery we'd rather do.
Exactly.
I see.
That's not what you wrote.
This question is rigged.
You have to correct a GDV or
if I'm doing surgery, then there's a problem. Like, that's not ideal.
We're on loss.
If I had to just throw it out there, I'd probably do the foreign body surgery just because I don't want to be dealing with any sort of splenectomy that may or may not need to happen with a GDV. And I think I'd have better chances with the linear foreign body. But that being said, if I'm doing surgery, there's a problem. Everybody died at the hospital or something, and I'm the only one.
Everybody died.
Yeah, like that is not good.
This is Jeff, and I'm gonna do the GDV. It's fine. It's probably the same problem as Brandon. It's like if I'm in an abdomen, something bad has happened to every other doctor within a 30-mile radius. But we'll figure it out, I guess.
This is Adam. Yeah, I'm the same. Why am I doing surgery? I hate this. I would pick the foreign body, but I'm telling you right now, I'm not RNA-ing anything, so that purple tissue better pink up. It better find a way, So I'll take out the object, but that's about it.
Those are all good answers. I like it. I do have one more.
Those were all terrible answers. What are you talking about?
Well, wait, what about you?
It does. I don't care either way. They both sound fine. I mean, we'll do. I guess.
Okay.
I mean, it doesn't matter. Out of the GGV, I mean, those are interesting, and then you got to tack it afterwards. I mean, splenectomy is fine if we need to. I mean, it's just ligating.
Chris is just sitting here like, I'll do both. It's fine at the same time.
This is the most annoying. He's like, I'm just a Tuesday. It's like, I would be in there fighting for my life.
I mean, I'd be cussing up a storm while I'm in there, but I'd be like, yeah, let's do it. I mean, I don't know. We both don't. I guess a linear foreign body seems worse to me, depending if you're doing RNAs, and that sounds more difficult. Yeah, I guess I'd do GDV over linear foreign body if I had to pick one. Next one is, would you rather unblock a cat or stabilize a DKA cat?
This is Brandon. That's easy. The DKA is easy.
All right.
The stabilization for a DKA is just fluids. So for the most part, that's step one. Give it fluids for 6 hours.
Also an annoying answer.
Check the potassium. Done.
This is Jeff, and I famously have never unblocked a cat, even though I did so much ER in my rotating internship and GP, so I guess I'll take the DKA cat.
This is Adam. I think I'm gonna take the unblocking the cat on this one. I think I'd rather unblock a cat than hospitalize a DKA. Yeah.
And this is Chris again. I'm with Adam. I'd rather unblock a cat any day than deal with the DKA.
Oh, fitty.
All right. Well, let's get into this episode talking about different anti-itch medications, going through the different tiers. We're going to be doing the S, A, B, C tier ranking. So S is the top tier, and then A, B, and C are going there after. So the different medications that we have or groupings that we have are steroids, topical versus systemic, antihistamines. Those are your Benadryls, Zyrtex, hydroxyzine, your JAK inhibitors, which include Apoquel and the new medication Zermelia. And then you have Cytopoint, and then some supplements, immunotherapy, and then some other fun ones we'll talk about. So I guess first on the list is, where would you guys put steroids?
This is Brandon. S tier or God tier or whatever comes above that is probably where steroids should go. Just generally speaking, when it comes to anti-itch. But I am going to defer to the expert in the room when it comes to these specific problems in patients.
Yeah, like I was actively just going to wait to go last on all of these. This is Jeff. I think steroids are easily the SCSS tier of this category, with the caveat that they need to be used appropriately. I am very pragmatic about my steroid use, so by far, as far as control of itch, it's going to be the best, especially if that itching is coming from allergic itchiness. And it's really important to just use them responsibly. So if you're going to start a steroid, don't just start a steroid for a few days and say, here you go, let's see what happens. I'm always looking for, does this patient have, is it a part of my plan to work them up for something? Why are they itching? I'm always looking for underlying causes and when I'm going to get them off of steroids. So I'm always sending them home with an exact plan, how many days they're going to be on this medication, and then just looking for reasons of why are you itchy, which you should probably do with all of these products. But it by far is going to be the most powerful, also going to have the most side effects.
This is Adam. Yeah, it probably makes sense for you to go last so you can listen to all of us and then tell us how wrong we all are. That being said, I'm going to agree with the dermatologist. I'm going to put...
Weird. Good answer.
I'm going to put the steroids in the S tier. They're just so good. All the patients that I've had, I've had some patients with some pretty crazy looking skin that I've tried some other things on before that just haven't done the trick. And then I put them on a course of steroids and lo and behold, they're doing a lot better. And we're even able to get them off that steroid and then get them transitioned to something else for maintenance. But again, yeah, I've had great success with steroids. Obviously, again, side effects are something you got to watch for. But yeah, definitely going to put them in the S tier in terms of helping control itch.
And this is Chris. I mean, again, not going to disagree with the dermatologist. I do feel like we can almost have a full episode of just tier ranking of different steroids, because there's just so many things going from topical down to our systemic ones, and then going down, we have prednisone, you have prednisolone, depomedrol, dexamethasone. I know I'm missing a few more. JT, any more you can add systemically?
Yeah, I can. That's for the sake of time. There's just no way. But I did want to comment, like you mentioned, like the systemics are not the same as topicals. So if you have a case where you can use systemic, like hydrocortisone is a really weak, not very potent steroid. So anything that's only just a little bit itchy in one spot or a hot spot, that might go better, versus if I'm using something super powerful like triamcinolone or dexamethasone in cream form, that might be for something a little bit more serious. But in general, I try not to use topicals for more than 14 days in a row, or you can get the skin starting to thin. And across the board, topicals aren't going to control itch over the whole body. So actually, you might put topicals. And for me, topical steroids aren't going to be S tier. I'd put them probably in like B, depending on the potency you're using.
Yeah, that's fair. And that's probably where I would agree with you as well in putting that, because again, you can't treat it everywhere. I feel like a lot of times, even like neopreduff we have here as a topical, we kind of just use it as a Band-Aid for treating, hey, a dog's been licking its hot spot for a while, but here, try this and see. And owner's just like, okay, great. And they love to put it on it and treat it with it, but it's not again, I feel like systemic steroids are a lot better than topical steroids. So, but again, we all agree steroids in general, S tier. Going down to the next thing would be antihistamines. Where would you guys put this? I mean, again, we can kind of split up the list a little bit, but Benadryl, Zyrtec, hydroxyzine, where would you guys rank this?
This is Adam. With antihistamines, sometimes I'll talk to clients who say their dogs are, mildly itchy. They may even be there for something else, and they're like, oh, they're a little itchy. Dog doesn't show any signs clinically of an itch, no skin lesions to note, but owner just says they're a little itchy. Sometimes I'll recommend starting with antihistamine. I do let them know that, it's a small percentage of dogs that are actually controlled with antihistamines for their pruritus. But they're cheap, relatively safe. They can get them over the counter. So it's just a kind of a quick, easy thing they can try before we jump to some other more expensive prescription type drugs. So I kind of try to let people know, like, hey, this may not work, but it may be a reasonable starting place if it's very mild. Because they're not super effective in all dogs, I'd probably put them in the B tier. But again, sometimes I'll use them as a starting point.
How about you, Brandon?
Yeah, I mean, I think they can be effective. I think it's kind of situational, right? Like this is more for like acute pruritic type stuff. If I had to guess, that would be where they're most effective. And as far as, and I'm interested to see what Jeff has to say, but for like long-term use, I expect there's going to be some sort of utility, but maybe not as effective as those more like acute flare-ups of pruritus.
And I'm going to go just before JT drops the hammer on this one. So for me, I would put them B, maybe even C tier for the most part. I know they talked about Benadryl, one of the talks we went to, like doesn't really do anything for itchiness in dogs. I'll still use it for like if they have like a vaccine reaction, but this was in talks with Apoquel over Benadryl. I'm like, yeah, Benadryl doesn't do anything really, except I think it was 2% is a number that they threw out that actually helps with dogs. But again, don't quote me on it. But yeah, I'm a B or C tier.
So this is Jeff. Antihistamines, there was a study showing that they help with allergic itch in about 10% of patients. So they're really not great for itch control for most patients. However, I do think, and I was interested to hear Chris and Adam, and you too, Brandon, like your experiences with it, because my population of patients is not the exact same as yours, because I certainly in specialty world, I'm going to get the most itchy, the most severe allergics compared to the ones I saw even in general practice. So I think they live kind of like you were saying, Adam, best for patients who have very mild itch. I think a great strategy as a GP is if you have a patient coming in for like their whole visit has been something unrelated to allergies, and you're like one butt cheek out of the door and they're like, my dog's itchy too. And you're like, all right, well, you could do, let me pop a dose of antihistamines on your discharge so you can try it out and just let me know. And then I'd recommend scheduling a follow-up visit just for the skin so you can actually address the skin as a separate thing and give it the time it needs instead of trying to shove it in to a 2-minute conversation at the end of a vaccine appointment or honestly, literally any other reason you're there for the vet. So because they only help in about 10% of cases, I think my population, it's even less that they help. I don't even recommend them anymore. But I think if I was still in GP, I think they have their place for the very, very mildly itchy dogs. But I don't know, anecdotally, maybe cetirizines edges out a little bit for me, but I put them solidly in C for my use. But I could see, maybe if I was still in GP, maybe B. But for my population, C.
So I think for that one, it's pretty split. B, C. I don't know. Where'd you have it, Brandon?
I was going to say B, but my experience now with it is so limited. I only really use it if we're poking something that might be a mast cell tumor, and just to minimize the risk of all that activation from the histamine release. But as far as like itchy patients, my experience in the past 3.5 years is very limited.
So yeah, I guess, I don't know. I'll just put it in. You're limited. I guess B tier will be my vote then if I had to put it in, because it is pretty safe. I don't really have any reactions to it. Adam was B tier, and JT said he would if it was GP. So, alrighty. Next on the list are our JAK inhibitors, Apoquel and Zenrelia. I personally don't have much or any experience with Zenrelia. I've just read about it at this point. Apoquel I use all the time. Where do you guys put these medications?
This is Adam. So for our JAK inhibitors, I'm the same as you, Chris. I have not used Zenrelia, so I cannot speak one way or the other on it. Apoquel, personally, I feel like it works pretty well. Relatively safe. Obviously, it's kind of expensive because it does work pretty well. I know we haven't gotten to it yet. Run-of-the-mill itchy dog, I typically reach for Cytopoint first. I'll kind of get into that when we get to Cytopoint. Apoquel I'll usually use more when the skin is incredibly irritated. So if the skin's really red and inflamed, and they have a lot of secondary skin lesions, just because based on what I've heard previously, it does have a little bit better effects with inflammation. And I feel like I've kind of seen that as well, in practice. I feel like Apoquel does tend to help a little bit better when the skin is really inflamed. So that's when I'll reach for Apoquel a little bit more. Obviously cost is a big one on it. It is kind of expensive, but overall use for me personally, I'd probably put it in the A tier.
This is Brandon again. For me, I will like, just thinking back when I was a GP, I did have a couple of patients that I would put on Apoquel initially, and I had like a very positive response really quickly. Not the same maybe as steroids, but like patients would respond within sometimes as quickly as the same day, sometimes as quickly as a few days after the fact. And for those dogs where it's used, where it's indicated in those specific diseases, it is very effective. So generally speaking, for me, I'd put it in like A tier. It's a really good drug. There's JAK inhibitors in general. I have no experience with Zenrelia, the other drug that's very similar to Apoquel. But in my experience with Apoquel, it's been great.
And this is Chris. Again, I agree with both Adam and Brandon there. It's a good drug. Really no side effects or anything. I like Apoquel a lot. So yeah, I kind of use it just like Adam does. It's cost dependent too sometimes. Sometimes I'll use it over Cytopoint. It just depends on kind of talking with the client on what we're doing. But yeah, I would say A tier for me. Almost flirting with S tier just because of it's, again, there's no real side effects, but cost wise, it just brings it back down.
This is Jeff. Yeah, I would put Apoquel in A tier as well. I think specifically for itching, it's very quick acting. I agree with you, Adam. So it is labeled, and how it works in the body is it does have some inflammation control, whereas some of the other ones don't, like Cytopoint. So it is better for a patient who has some inflammation on board and extra lesions. So I think you're super correct about that. I'd say it is also anecdotally, it's used. There are reports of it being used for a couple autoimmune diseases. So I'm not going to go into deep detail about that since today's all about itchiness, but there are reports of that. So it's a little bit more versatile than simply for itch, which is very interesting. And I also like that it is a tablet that you can start and stop. So unlike a steroid, you don't necessarily have to taper it down really slow. You can start it the day of itchiness getting worse, and it's supposed to be working, I think, within 30 minutes, and then the half-life is 8 hours. So around 24 hours, it's probably completely out of the body as far as I know. And I have even had owners, when I'm using it for maintenance control of an itchy dog, like use it every other day or stop it in the winter if you're using it long term. But I do manage my cases with a little bit of blood work every 6 to 12 months, depending on the case, to make sure it is not causing any other issues. But I think that's the only reason that I kind of keep it out of the S tier. So I think it's a good solid A for me. And then I can briefly mention Zenrelia too. So that's the newer JAK inhibitor. Basically, I've been telling my clients, like, another company was essentially just trying to see if they could do a better job than Apoquel and compete with them. I've had a pretty good bit of patients who've been on it. I'm pleased with its use so far. I've used it, as you can imagine, in a lot of severe cases when they're failing everything else that I've tried them on. I think anecdotally, I've seen it work pretty well for some of my failures of other itch medications like Apoquel and Cytopoint. I am, caveat, always checking these patients if they have lesions for infection. So making sure that's not the reason things are quote unquote failing, because secondary infection will make all anti-itch medications seem like they're not working. So if I'm looking at like an apples to apples patient, I've been trying it for a month just to see how it goes. I so far am gonna also I'm gonna leave it with Apoquel and put it as an A so far. I think they both work pretty well. I'm pretty pleased with the quick onset of action for both. And I've been checking a little bit of extra blood work with the Zenrelia since it's brand new, but I think it's really reasonable. And I've been using it a little bit more before going to a steroid for a patient that's not extremely inflamed. So if you're in all out of sorts and really, really uncomfortable and miserable, like 10 out of 10 itchiness, I usually use a steroid to get things under control first. And then I'll switch to something like Apoquel or Zenrelia or even the Zyrtec, depending on how the recheck goes.
I had a quick question about Apoquel and JAK inhibitors in general. And Jeff, you might know this more than anyone else, just being more up to date on the literature. For these drugs, is there any increased risk of like neoplastic effects or anything like that in patients? Is there any data on that?
So the long story short is there's a very, I guess, a longitudinal study with Apoquel, and there's been a few showing that, forgive me for not knowing the in and outs of the details of the study. I read it a while ago, but basically there was a very long study where two groups of dogs, one dog was on Apoquel, one dog was not. And some of the dogs that were on the medication did have a higher incidence of some benign skin tags, I think some papillomas and other things like that. So there is a labeling to not use it in patients who have cancer or history of cancer. I have also heard of a report of it being used for cutaneous lymphoma, which is wild. So based on it, so it's interesting because I'm like, all right, well, I tend to go by, yeah, it's interesting. I go by what the label says, but there are so many more uses for it than I think we know. And I just kind of try not to use it in patients who have a history of cancer. I'll also mention, I completely forgot about Zenrelia. There is that labeling, just like Apoquel, that they can't be used for patients who are under a year of age. And part of Zenrelia's deal with that, I don't remember for Apoquel, but related to an FDA study, there were some puppies who got sick taking Zenrelia according to study parameters when it was used at like much higher than daily dosing. I think it was like 3 to 5, something much higher, which was required from what I understand. So make sure to not use it in patients who are young. And it also can't be used with, it has to be withdrawn, I believe, 1 to 3 months before vaccines, talking like not allergy vaccines, but like rabies, distemper, all your general practice vaccines, and then a month after. So I do think that is limiting, and that is related to the puppies in the FDA study that were vaccinated and were also, they had diarrhea, I believe, and then they just got sicker when given really high doses. That I believe it was repeated, and the dogs did fine. Dogs that were not sick at those high doses. But I've been kind of giving my clients that kind of disclaimer. I'm like, this is on the label. Be aware of it. I am following the label just because it's new, so I feel like we need to. But I do think that's a limiting factor. So especially if there's any GPs out there listening to this, I do think that's super important for Zenrelia. So you have to decide your comfort level when using it.
Sweet. Yeah, that's basically, I want to hear what your information was on Zenrelia. So that was good to hear all that information on what you're saying there. So I think we all agree it's a A-tier medication, kind of flirts with S tier in some things, but overall there. So moving into our next one is Cytopoint. We kind of alluded to it a little bit, but where would you guys list this one?
This is Adam. I'll jump in here. Cytopoint is probably what I use the most for itch. Couple of things that I like about it over Apoquel. One, it's just an injection we give in the hospital real quick, labeled to last 4 to 8 weeks. Takes owner compliance out of the question. They don't have to worry about giving a pill. Dog starts to get itchy again in 1 to 2 months. They just bring it back for a shot, and we're good for another 1 to 2 months, as long as the dog responds well to it and is doing good on it. The other thing I really like about Cytopoint is it's just incredibly safe. And so for us, and this is going to vary obviously clinic to clinic, but the clinic that I work at the most, they do require blood work every 6 months for any patient on any chronic medication. They don't require that for Cytopoint just because it is so safe. It's an injection we give in the clinic, whereas they do require that for Apoquel because obviously we want to watch things like the liver values and things like that. So takes that out of the question as well. Not saying we shouldn't do blood work on all patients, at least yearly. Sorry, Brandon. But it does save the clients a little bit of money in that regard as well. So I like kind of those two factors about it, and that's probably why I use it the most. So overall, I'd probably put it in the A tier as well.
Yeah, I don't have a whole lot to add. It's Brandon again. I will say from my personal experience using it when I was a GP, it worked well. We used it a lot, and just like Adam said, the convenience factor is much appreciated to owners. So I would throw that up there in A tier with Cytopoint or with the JAK inhibitors, just because of those things and its effectiveness.
And this is Chris. I'm in agreement with there as well. And I know we can also sometimes get varied length of time on how long it works. So it sometimes ends up being a little bit cheaper for people to use it instead of using Apoquel. So again, it's also more convenient. So I mean, I use Cytopoint on my own dog, so yeah, Cytopoint's an A tier for me.
This is Jeff. I think it lives in A. I think it's right along Apoquel and just patient to patient on when you use it. I think it is, you have to keep in mind if you're doing a diet trial with Cytopoint, I usually will push out to a full 12 weeks versus the classic 8 weeks. That's just based on research. It is often used in research for, they like the 12 weeks because it can last up to 8 weeks. And some people think even a touch longer, just not at that 80% efficacy level. But I think other than that, rarely, I was going to ask you, Brandon, have you ever in your internal medicine circles heard any adverse reactions with Cytopoint?
Not specifically. I'm not even familiar with any like individual case reports. I'm sure there's probably something out there of one dog that probably had something else going on, but otherwise, no.
I was going to say there's a few internists who don't like it being given in like IMHA and a few autoimmune cases. My understanding, like literally speaking to Zoetis, they were like, the mechanism of action, it should not be able to cause that type of reaction. So I've seen a single Cytopoint reaction in a case that did get hospitalized, but for the many thousands of dogs I've used it for, it has been the biggest problem is that it may not work versus patients having any true adverse reaction to it. So it's just extremely rare. So I think it's a really good option for most dogs.
Yeah, I would agree. Like generally speaking, yes, like any foreign substance could potentially stimulate the immune system and cause those effects again in a patient with an underlying immune-mediated disease. But I mean, it's a monoclonal antibody, correct? Like that's what Cytopoint is. So generally speaking, it should be very safe. And if a patient like just really needs it for their quality of life, then I'm going to be supportive there and just give that caveat that there is this mild risk of it potentially stimulating the immune system in an aberrant way.
Yeah, this is Jeff, and I'll make one last comment on Cytopoint, which is one thing that's super nice about it is it can be used in less than a year of age, so it's often an easy first line where you don't have to worry about it causing other problems. And I'll also note that single case that I had issues where that patient was hospitalized, it was also a patient that had a lot of other comorbidities and a long history of other immune-related problems, and it was just like not a super healthy pup. And we did report it to the company, and there was more that went on than just that event because it was so rare that we reported it. So I would encourage people to do that in general.
Good information there on Cytopoint. So kind of for the sake of time, I want to skip one, and I think it's more specific to dermatology anyways, which is immunotherapy. So I have never used immunotherapy. I don't know if Adam's ever used immunotherapy. Brandon may have, but we're going to skip that one for our listing here. And we're going to get into kind of 3 different ones real quick for the sake of time. Supplements, basically just fish oils would be the one here. Then a topica, which I don't use as much, but I know we do use that, which is immunosuppressant. And then I know these are JT's favorite right here. This is top tier stuff. Coconut oil and motor oil. Where would you guys list these 3 or 4 different medications or not medications?
This is Brandon. Fish oil, I think, is great. You know, I'm not as familiar with the like anti-itch properties, but generally speaking, just the anti-inflammatory properties that I'm familiar with for things like renal disease and other diseases, I think it's great. So I'm not surprised that it would give like a benefit, probably on the lower end of the tier list, just because of its like efficacy towards those things. But it'd be a good like adjunctive medication. So as a sole proprietor type of medication, only giving that, I'd put it in the C tier. If it's being given with other stuff, maybe bump it up just to round out everything else. Atopica, I think, is a really good alternative for like a patient that needs immunosuppression to control their itch when they want to avoid the steroid side effects. So I'm interested to see what JT's experience has been. And then I'm just not even going to acknowledge coconut oil and motor oil.
All good answers there.
This is Adam. So yeah, starting with fish oil, I'll recommend fish oil sometimes for dogs with really dry, flaky skin. I do tell owners that you have to give it some time to see results. I tell them I think it's typically a minimum of 8 weeks before we even see results with it. As far as actual anti-itch properties, I do not know. I will defer to the dermatologist for that. But I don't recommend it a lot. It's usually just with the dry, flaky skin. I'll put that in the C tier. Cyclosporin, Atopica, again, I don't use that a lot as well, mainly because a lot of the clients that I'm working with are, it's just cost prohibited for them. So I don't have a ton of experience with that. And then coconut oil, motor oil, it sounds crazy, I know, to people listening, but these are things we actually hear in the clinic. No, don't do it. It doesn't work. It's not safe. Don't do it.
And this is Chris. I agree with what Brandon and Adam. Fish oils, I use them kind of just as needed type of thing. I actually refer to the Colorado State's fish oil chart. They have a whole chart where you can kind of see by weight range and then just tell them the amount that needs to be given. So it's a good thing that I just show clients that and they take it home with them and add it there. Atopica, again, I don't use it a whole lot. When I do use it, it's I mean, it's rare, maybe once a year at most. And then the other two were more on this list, more to just see if we can get JT mad about using it as an anti-inflammatory. But yeah,
you did.
They are jokes. Coconut oil and motor oil are never recommended.
Okay. I will not harp on any of these as my life goal. This is Jeff. Okay. So coconut oil is not going to hurt anybody, but I've never seen it control itch. I'm not going to give it a ranking. Motor oil, I'm going to ignore. Fish oil, I agree. 2 to 3 months to see it start working. It can be efficacious for itchiness. I've never seen it change a patient's life night and day. I think it helps more for the dryness, and maybe that also helps with the itchiness, but it has some anti-inflammatory control. I would give it a C, personally. Atopica, I would give it a B. I agree with Brandon. It can help you reduce some of those side effects for a patient who is stuck on steroids. All of these are assuming you've done a full allergy workup and maybe nothing else is helping. So it's more of like the last choice. It also is very expensive. It can have vomiting and diarrhea side effects. If used at appropriate doses, it's rarely truly immunosuppressive, but more immunomodulatory for some of those really, really chronic atopic cases. It also takes about 4 weeks for it to start working when used. So I do a minimum of a 2-month trial when I use it. But I give Atopica a B. Also, the name brand is more bioavailable than the modified cyclosporin version versus regular generic. So I don't use regular generic, but I will use sometimes the modified generic for costs. Oh, and how dare you try to skip immunotherapy? I'm going to take 10 seconds right now. Immunotherapy should be used in any patient after you have proven that they are clinically atopic. You've diagnosed them with atopy. And a lot of people haven't used it because most allergy testing, I think, is done with dermatologists. But I usually will allergy test something for environmental only. Do not do food allergy testing. It is not accurate enough yet. An environmentally allergic dog, you do environmental allergy testing, start them on immunotherapy, which is mostly those allergens mixed with sterile saline, but it needs to be given for close to a year to see it begin working. So it's super slow. I actually give it a secret S tier because it's the only one that directly treats allergic itch, whereas the other ones don't, but it does not make every patient feel better. So there are a group of patients, the efficacy, depending on what study you read, is 65 to 70% at reducing their allergic flares. So they still may need some of those other categories. So I imagine some derms probably put it in A, but it's by far the safest and easiest on the body. Next safest would be like Cytopoint.
It's a bit of a commitment though, right?
A huge commitment. Most patients are on it for years because it's working, but I do give I recommend a minimum of 1 year to see how we feel about it. And then most of the time we're continuing it because it's let us use less Apoquel, less Cytopoint, etc.
Side note from me, while we're on immunotherapy, I've seen it help with cats that are asthmatic because of the allergic response. So I've used it. I've worked directly with our derm service when I was at Iowa State to work up a cat that had allergens that they started immunotherapy and helped manage its asthma. And as a human who was on immunotherapy, I think it works.
Yeah, that's a good point, Brandon. I do occasionally get an internal medicine asthma cat that will come through just for immunotherapy, and I felt like it helps a lot.
That was a lot of good knowledge dropping right there. Immunotherapies. Again, I think it's more of a just not being able to use it in GP is why we just don't. I mean, I think we can. I mean, we can give it, but not having the testing for it and doing the testing and going through everything. But no, that's good to know. I mean, I feel like if we had clients that want to do it, I usually just say, you should go to the dermatologist and then we can kind of take over from there. But yeah, that's definitely some good information. All right. So rounding up this episode, we're going to do one of our typical outro questions. Is there a hobby that you guys want to try that you've never done before?
This is Adam. The biggest thing that comes to mind is Brandon always talking about going snowboarding out there. I've never been snowboarding. I have been skiing once, but I think snowboarding would be fun to try. I feel like I would somehow bust my ass, but I think it would be fun to try sometime.
Yeah, busting your ass is part of it for the first few days. So I recommend coming for at least 4 days if you can swing it, to like truly enjoy it.
This is Jeff. I'm going to say I actually just started one that I don't even know if I've told you guys about this yet. So I started boxing about 3 weeks ago. I go once a week right now. And I had wanted to do this for like a year and a half. One of my friends here in Louisville is a professional boxer and works at Title, like the chain boxing place. And I really enjoy it. I'm not very good. My knuckles hurt all the time. I was very much an amateur, but that is my new favorite hobby.
Is this traditional boxing or kickboxing?
Traditional.
Okay. I love Muay Thai. Like I started it back up when I came out here, which is like Thai kickboxing, but I'm hoping to get back into it because when I move into my hopefully new house soon, we'll be like 20 minutes closer. So nice. Yeah, that's awesome. I really like that. While I'm chatting here, I think about stuff all the time. I kind of like, it's like, I don't know. I have like ADHD when it comes to like cool new things to do. For me, something that I hope to get into down the road is snowmobiling. I think it'd be a lot of fun out here in the wintertime. A lot of people enjoy it. And then it's just fun to be able to have a snowmobile and go out into the backcountry and also go snowboarding and then being able to ride out without having to hike out.
Those are all real good. I'll go. I mean, I haven't had, I have a whole list of things that I want to try, but I guess one more that I can probably do soon is pickleball. I have never played. Looks fun. I think Natalie and I can probably pick it up pretty quickly. And then, with Adam, I do want to learn how to snowboard. I've tried one time, though, when I was like 12, and I was terrible. I fell the entire time. We went back to the ski place, and I just went for skis. I'm like, because we're on there for a day. I'm like, I know how to ski. Let me just get back on skis. Thank you once again for joining us on the Dogtor Bros.
If you would like to support us, please share this episode with others who may be interested in today's topic, and leave us a 5-star review on Apple Podcasts, Spotify, or wherever you listen to your podcasts.
Would you like to influence our next episode? We love hearing your opinions and thoughts. Your comments may be our next topic.
Please leave us suggestions via email at thedoctorbros@gmail.com, DM us at thedoctorbros on Instagram, or leave us comments on our posts. Again, this is Brandon. You can reach me at Dr. Mason IM on Instagram.
And this is Chris, and you can reach me on Instagram at dr.chrishernandez.
And this is Jeff. You can find me on TikTok or Instagram at DermDrJeff, DermDogtorJeff.
And this is Adam. You can reach me on Instagram at DrAdamDVM. That's DrAdamDVM.